This is something that always comes up, particularly when you speak to people of the Indian subcontinent.
Right.
They take the view, oh, maybe we are genetically predisposed.
Yes.
I think in terms of genetic predisposition, if the lifetime risk for an average American is 1 in 3, he or she is also genetically predisposed. So the question is, we dwell too much on small differences between populations.
And also things we cannot control. Sometimes it is easy to just let it go.
Correct.
You know, I think the India issue came up with respect to the World Health Organization, publishing that in this year, 2010, we were expecting that, the heart disease rates in India to be very high. So number of cardiac patients are expected to be about 60% of heart disease coming from India. And I think that's where a lot of doctors and scientists started thinking, well, Indians are perhaps predisposed to heart disease. But when we look at it historically, it was not always the case. And I'm curious about your thoughts on that.
Yeah, but I think it's difficult. It's difficult because when you think about it, in 1950, the life expectancy of the average Indian was under 30 years of age.
Right.
Okay?
Right.
But now that's gone up to 64 or 65 years. So on the one hand, health has improved.
Right.
And people don't develop coronary heart disease or diabetes
overnight
that often before the age of 30.
Sure.
So I think one of the aspects may be people are living longer. That's clearly an aspect.
Right.
But India, there are other special features. Like, for example, it's not a physically active population. I mean, I often remark that in the 2008 Beijing Olympics, China led the world in terms of the most number of gold medals.
Right.
And India celebrated winning 1 gold medal. So I think
that's pretty typical from India.
And also it is a culture that's heavily into high carbohydrate
diets. Yes. They
probably,
enjoy life there.
It's probably, and there's a lot of diverse food, diversity of food, etc.
Right.
So I think all of these factors, and plus the other thing really is this issue of maternal undernourishment. I mean, if you look at India in the last 50 years, there's been a lot of maternal undernutrition, low birth weight babies, etc. So that's also contributing to the rate at which diabetes is increasing, because these children are now surviving, but they're at high risk of developing chronic diseases.
Okay. Well, on that note, especially you mentioned maternal undernourishment. One of the papers I read talked about how, both under and overnourishment can obviously be a problem. With respect to the problem here in the U.S., if someone has body mass index, which increases by 1 unit, it turns out that diabetes risk increases almost 12% for every unit increase in BMI. Right. That's very formidable. And so when we talk about risk factors, obviously they are not universal. Every country is going to have specific things we have to deal with. But talk to me just a little bit about the United States, especially in Europe and the Western nations. What are the specific things that we can really look at? I mean, for example, we know diet and physical activity. But a lot of people struggle with diabetes versus pre-diabetes. So at what point should people start getting really concerned when the numbers go up above 126 mg/dL? Or, when do we really start getting very serious?
I mean, essentially, this is a very important question. All of us have glucoses in our blood,
right.
Okay? And the definition of diabetes is to some extent arbitrary. So essentially, based on the best knowledge we have in terms of science, diabetes is defined as a fasting glucose of 126 or over, or a 2-hour glucose. That's a glucose after challenging the system with 75 grams of glucose to drink, of 200 or over. And what we regard as normal is a fasting glucose of less than 100, or a 2-hour glucose of less than 140.
Right.
So the group in between, that's either a fasting glucose of between 100 to 125, or a 2-hour glucose of between 140 and 149, that's loosely put together as pre-diabetes.
Oh, raising a red flag too.
Yeah. So essentially, the reason that group is important is because they are at increased risk of developing diabetes in the future.
Right.
And secondly, that's also the group where a lot of prevention trials have been done so far. So the question is, what do we do at different stages? I mean, my personal view is, every normal person, even if you don't have diabetes or pre-diabetes, I think it's sensible to follow a healthy lifestyle, because you don't want to develop when you want to try
any of these conditions.
Exactly. Once you develop pre-diabetes, so in other words, once your fasting glucose is above 100 or 110, or your 2-hour glucose is above 140, and suppose that gets identified, through some test, then it's important to start a very aggressive lifestyle program. And what we mean by an aggressive lifestyle program is about 30 minutes of physical activity daily, at least 5 times a week or more, and trying to keep the body weight down. So if somebody is 200 pounds, try and lose 5 to 7% of that weight. Secondly, and do it gradually, because again, studies show it's not an all or none phenomenon. For everything that you do extra, there is extra
You get some
benefit.
reward.
You get some reward.
Right.
So I think that would be the way to deal with pre-diabetes. But in general, the benefits for prevention seem to be highest for people who already have some elevated glucose. I mean, so essentially, that doesn't mean that we should not be advising others
For
who
those
are,
who are
not to follow.
Right.
But in terms of where do you target your diabetes prevention efforts?
Is at the pre-diabetes level. And I think especially also in children and adolescents now, when
Absolutely.
this problem has become so huge.
Yeah, but again, in children and adolescents, it still is a rare disease. Thank goodness for that. But we have to, I think that's the age. If something happens between middle school and high school, children start losing their physical activity and start putting
recess
on
gets
weight.
cut off in middle school too.
So I think that's why it's very important to start reinforcing those habits in school.
Physical activity.
Yeah, exactly. And we spoke about India and China. That's a problem they are facing too.
Well, I think, I was talking with Bill Dietz at CDC just a couple of days ago, and he mentioned how the emphasis on competitive testing and scoring so well in schools, although important at its own level, of course, takes the emphasis away on sometimes from kids being kids a little bit and just playing and just being out there. And there is also not that natural kind of sociality to life as we once used to have. For example, when I was a child, we went outside and played, and that doesn't happen anymore.
Absolutely. So, and there might be a paradoxical situation here.
Right.
Because on the one hand, the academic pressure is dissuading children from being physically active.
Right.
But there is some research suggesting that physical activity improves academic performance.
I wouldn't be at all surprised, even if that's anecdotal, because I think children have a surplus energy, and when they are able to discharge that, they feel better balanced.
And also, there are studies suggesting that physical activity improves certain areas of cognitive function.
Yes. Very
so
much
when you combine all of that, so essentially, I think the human habitat is meant to be physically active. I mean, I think it's meant to be physically active because, we did. If you looked at our ancestors, the apes and the monkeys, they're physically active. And also, they avoid very high fat food. They avoid large quantity of carbohydrates. They don't consume refined food and processed food. There's a paper this week suggesting that processed meats increases the risk of heart disease than the non-processed meats.
Right.
So I think there's something about processing of foods,
definitely,
refined sugars.
And I think we find that across the board, even every food group, whether it's carbohydrates or fats, even we find that the more we bleach and process than relative to the pure pressed, for example, we're not getting the nutrient levels.
Yeah, I mean, there was a paper published in Chennai 2 years ago saying rice increased the risk of diabetes, but when you really examined it, it wasn't rice per se, it was polished rice. So again, that's a population which for centuries has had rice as a staple diet.
Right.
But what's different today is that rice is getting refined.
And that makes
so that's what
it raises your glycemic index.
Absolutely,
and low, very much so. Venkat, we'll conclude shortly. Just a quick question with respect to drug use. Most people who are pre-diabetic or in that borderline range get put on metformin or another drug, acarbose, or one of the others, very, very rapidly. Do you feel that is perhaps good as a primary line of treatment, or should it be secondary, perhaps, given all these data that is showing us what lifestyle changes can do?
Actually, two things. Number one, the diabetes prevention program in the US directly compared metformin with lifestyle.
Okay.
And lifestyle was twice as effective as metformin. So again, that was a classic example of a trial directly comparing those two strategies. So from that, I would conclude that lifestyle should be the first approach, and an aggressive lifestyle. And people, need to give lifestyle a fair chance. It's not about a 5-minute consultation where you wave your finger and tell the person to lose weight. It doesn't work that way. You require a program. And again, this is where some progress is happening. Like the CDC, the ADA, and some academic groups are now working with health insurers to get the YMCA deliver the lifestyle interventions, for example, and the health insurance companies, particularly the United Health Group has agreed to doing this, would reimburse the cost of healthcare.
So there's an incentive to start.
So that's number one. Secondly, after trying lifestyle, there might be a small group of people who still are at very high risk. I mean, these would be people who have both a high fasting glucose and a high 2-hour glucose.
Right.
In that group, adding a metformin may have a place.
I see.
But I personally believe that that should be a gradual approach, a stepped-up approach. And this is exactly what we are evaluating in our trial in Chennai. We start with lifestyle intervention, give it to everybody for 4 months. And then at the end of 4 months, if some people are still at high risk, let's add a metformin and see what difference it makes.
Well, that seems like a very reasonable way to look at it, and also a very low cost way relative to medication, which can get very expensive. Well, you know, it seems after talking to you that in spite of the fact that when we look at just the data itself, and diabetes seems so daunting, and the numbers seem so daunting, actually there is enough cause for us to be optimistic when we look at what is possible in terms of what is in our control. And
I mean, if there's one good thing that's happened in the last 10, 15 years, there's been a lot of good research, particularly intervention research. Currently, if we can apply everything we know about preventing diabetes in high-risk people, we can halve the incidence of diabetes. And if we can apply everything we know about preventing diabetes complications for people with diabetes, we can halve the rate of diabetes complications. Those strategies are available. And this is where we need to think of how do we develop systems capable of delivering this. Unfortunately, systems are not ready yet.
Yes, I think sometimes we can have the abstract knowledge and understanding, but then how to really bring it in a very practical fashion.
And I think this is where we need integrated systems of care. You know, like for example, more and more when you think about chronic disease care, whether it's diabetes or heart disease or asthma, what you need is well-organized, integrated systems
that actually deliver.
Because and so system reform and system organization is going to be extremely important. And again, countries that are rapidly changing need to start thinking about insurance models and reimbursement models.
To bring about the delivery.
Absolutely,
Venkat, on a final note, help me summarize what you would say just to the average person listening, or to the average School of Public Health student, or to lots of schools of public health often look at information like this. What might you say both to researchers and to the average person in terms of what is the best way for us to move forward? I know we can be optimistic, but if they had to do it at a personal level before the systems are in place, what can we do, and that will help us move forward?
Okay. Firstly, I mean, clearly diabetes is a major problem. It's a big problem, it's a costly problem, and it's growing. So research needs to focus on 2 dimensions. Number one, research aimed at better understanding the causes of diabetes at a biological level, and that needs to continue. And secondly, we should not forget about research to how do we take these great interventions and apply them in practice, which is a combination of behavioral and organizational research. I mean, that is very important to do. But in terms of specifically what people can do, I think essentially, when you look at the population in the United States, for example, 70% of people in the United States have at least one glucose measured each year for some reason or another. So, but what is lacking is trigger mechanism to act on it. So somebody goes to a doctor for something and they have a glucose done. If it's elevated, not diabetic, but in a pre-diabetic range, there's got to be a way of getting them lifestyle intervention. So good follow-up care, and the resources are there. It's a matter of connecting them. So that needs to happen. And as far as a person with diabetes is concerned, it is a complex disease where patient empowerment becomes extremely important because the person has to manage the disease for lifelong, and there are multiple aspects to the disease: blood glucose control, blood pressure control, lipid control.
It becomes even more complicated with type 1 especially, and that's also an issue.
So again, there you need, organized systems. I mean, like for example, reminding people, keeping them motivated. That's far more important than great expertise,
That doesn't actually get to people. Well, Venkat, this has been very informative and actually very positive. I feel that all of this research, we thank you for, because oftentimes, the average person feels the academics are academics and they don't get to them. But I think this information is very practical, and I thank you so much for your time.
Thank you.
Appreciate it very much.
Thank you.